Right, as you come in, mute yourself. I'm going to go ahead and get us started just with some very basics information that we'll repeat at the end just to keep us on time. I'm Dr. Lauren Oshman. I'm our program director for MCT2D. Heidi Dietz is my co-facilitator and co-director today. To start, I'm going to just flash this CME CE credit screen on, but you do not need to copy it. I promise we'll give it to you at the end of the presentation. And in order to achieve CE credit, we're going to ask you to complete the required evaluation. Here's our disclosure of financial relationships for this presentation and basic information that we always provide you about CE credit. All right, team, I think we're still manning the waiting room and noting that people will get stuck in the waiting room again as they move in and out of their phones or whatever they're doing. So I'll just ask the team to make sure we let people in. So here's our agenda for this evening. We're going to provide some basic clinical updates. It's always a part of the meeting that I appreciate, and we've got some really timely updates for you this evening. Then we're going to invite some of our wonderful practices to present what they've been doing to achieve best practices for UACR screening. After that, Laria Young, our team design manager, is going to talk about prediabetes, which we're really excited about. And then we'll end by wrapping up, explaining again what we need to do for learning community requirements for the year. So I'm going to kick off our clinical updates and then pass it over to Heidi and then Jake for some more updates. But first, I want to share, as we always do, what we've been doing since we saw you last at the spring regional meetings. We've been doing some really wonderful things with our data that I'll show you, as well as adding our very first social determinants of health data. We're now collecting race and ethnicity for our collaborative, which we're so excited about. We've been doing different programs. Rina Hisamatsu, our registered dietitian lead, hosted a very successful low-carb Train the Trainer event in June, and she's hosting her follow-up this week focused on registered dietitians. We're going to share some information on prediabetes, as I said, later in the presentation, and some tools we've created to support our UACR kidney screening initiative. And then we've revamped our learning community options that we'll show you. So I am just going to show you this graph because I really think it's wonderful looking at where we started as a collaborative and how we've grown the patients that are available to us in our quality improvement cohort. And if you see over the last 12 months, we have 150% more or 150,000 more patients, which is due to having different elements of data in our data warehouse. What's really important here is just in the last 6 months, being able to add patients with Medicaid insurance. And if that's about 50,000 patients here, that means 1 out of 5 patients in the data dashboard that we have Medicaid, which is pretty consistent with what we know statewide. And what a wonderful opportunity to achieve health equity and look at how quality varies and how we can improve it in these different populations. So we're really excited about that. Also, our last update, we're thrilled to announce the launch of MCT2D mobile app 1.0. We launched the app this summer. This was something that you asked for and we delivered, and we prioritized some of the elements you wanted first. So you can pick up your phone, download, well, I guess I won't show my phone. It's a spooky Halloween phone, but you can download the app while I'm talking you through it right now. So key features that we have placed in like the first generation of the app, we will be adding more, our coverage checker light. So you're going to be able to look on your phone and look for coverage information for CGMs and medications at this time. There's a lot of resources in there. So I took these screenshots a couple of days ago. I used the Jumpstart guide for my patients pretty consistently. Now I can go into the app and I can send them a link to the tool via text or email, and it's sent with the MCT2D phone number or email. Won't show your information and you can give that to them. All of the tools are really readable even on a small phone, and you can bookmark them for easy access. And so you can see here sending that I sent that to myself. Being in the know about MCT2D, lots and lots of events and news, but you can now sign up for events and join them from your phone. So if you're like me, always running late at lunch, miss our lunchtime learning events, you can join us during your lunch hour. You can take a walk and join us on your phone. So those are what we've been up to since spring. Certainly not everything, but some important things. And so now we have 154 people here, which is more than I thought were going to be here. So we're officially starting the meeting with the meeting ground rules. We really do want to make this interactive, even though we're not in person, but we understand how busy you are. We're so grateful that you're here with us this evening. And so this is our participation ground rules for the evening. You do not need to have your Zoom screen on. We will look at photos of babies or dogs or whatever you want to show us, but you do not have to have your Zoom screen on unless you're one of our presenters. You do need to be present for 90% of the meeting, but totally okay if you need to take a bio break. We're not going to have a standardized break time, so just take off if you need to. If you need to log back in, we'll let you in out of the waiting room again. We ask that you stay engaged, so we're going to have polls throughout the meeting, and we're going to ask that you complete 6 out of 7 of those polls. And then at the end of the meeting, we're going to ask you to complete the evaluation that will pop up as your Zoom screen closes. So now that we're all engaged, we're going to make sure our polling question is working. So I'm going to look for 154 responses to this question. Have you used the new MCT2D app? And then I'm going to ask one of the team members, if you haven't already put it in the chat, just to chat in those guidelines for participation. We've got 130, we've got 89%, almost everybody. And no more responses coming through. So I am going to say going once, twice, and closed. This is great. 20% of you have used the app and 33% are going to download it soon. So please feel free to do that and let us know what you like about it and what you don't. I guess I can share results. All right, so let's move on to our clinical updates, and we'll have some more polls throughout the course of the updates here. So we're going to hit some high points on our low carbohydrate eating pillar and medication pillar, and then turn it over to Heidi for some CGM and pharmacy benefit and insurance updates. So this is kind of the first update that I have for you. We really believe at MCT2D that there's no exact right diet for anyone with diabetes, but for many people, lowering or adjusting carbohydrates can be very beneficial for them. So this is a 5-year follow-up on a very low-carb diet plan. This plan was delivered remotely. It was monitored with BHB, beta-hydroxybutyrate testing, which is at-home ketone testing. And in this study of adults with type 2 diabetes, people adhered to a very low-carb plan with less than 30 grams of protein. Many of our drug trials are industry sponsored. This diet trial is sponsored by Virta Health, which is the company that delivers the intervention. So as always, a grain of salt when we think about how this applies to our patients. So here were the results. We've probably all taken care of patients who just aren't able to adhere to a very low carbohydrate diet long term. But what I think is important in this group of people who said, yes, I'd like to try it, about half were still enjoying it and adhering to it after 5 years. So as always, we want to personalize care to our patients. And what else is important here is the concept of diabetes remission. And this has a very specific definition, which means having an A1C under 6.5% and you're not on any medication. So it is truly just diet and lifestyle control. So of these individuals at the 5-year point, about 20% of them were able to bring their A1C under 6.5% without any medication. There's a different definition here, and that's diabetes reversal. And I will just tell you at the American Diabetes Association, there will be discussion about these specific definitions and names over time. But at this point, that just means you had diet control or metformin, and that was about a third of people. The other thing I think is really interesting is how did it affect the burden of medications for patients? And so people were able to stop some of their medications. And when you look at which ones they were most likely to stop, they were most likely to stop sulfonylureas and DPP-4 inhibitors. So if we repeated this study now, I would suspect our patients would not be on DPPs, but you can see on the graph on the right, just that decrease in medication burden over time, which is also wonderful for our patients. All right, so we know for many of us, it's really hard to provide this intensive counseling. We're really working hard as a collaborative to scale information and tools for you. And so Dina Grausda, one of our team members, and Rina Hisamatsu and some other partners have created the self-guided program called the Low Carb Journey. And we are going to be making this available to the collaborative in the future and continuing to offer our low-carb dietary interventions through our tools that we currently have. Okay, last update before I turn it over to Heidi. This is changes to incretin mimetic landscape in 2026. And so I think this is interesting. It's something that you all may know about, but if not, hopefully we'll learn something new tonight. So as you know, semaglutide and tirzepatide, they're incretin mimetics as a class, but they're also peptides, which are really defined as small chains of amino acids. I am not a physiologist or scientist in this way, but I'll explain the best I can. So what is the problem with trying to provide these peptides as an oral, non-injectable drug delivery device? They're really easily broken down by digestive enzymes. So Ribelsis is our oral semaglutide. It has an absorption enhancer tied to it, but it's still super finicky in terms of needing water and a certain amount of time before a meal to be absorbed. And so honestly, like patients may not be getting the full benefit of the medicine. So new on the market will be a medication called orforglipron, and we're all going to pronounce that 10 times fast. But this is really only one of several agents in development, and it is in the small molecule category, which means it is a small molecule. It's simpler, it's smaller, like this adorable little guy on the right. It's less complex, it's cheaper to manufacture. It can be administered in tablets. It can be stored at room temperature. And these are all really major challenges that we have with the cost and storage of the current injectable options. So I'm just going to show you super briefly the phase 3 trial of orforglipron for type 2 diabetes, and that was published in April 2025. And this was medication-naive patients with type 2 diabetes. They received daily orforglipron and lowered their A1C by 1.5%. And that is just about the same as oral semaglutide for type 2 diabetes. The weight loss is more modest than we see with the injectable medicines, but still higher than oral semaglutide. And my understanding is that this company is going to roll this medication out for obesity first, but should be available or at least submitted to the FDA in 2026. And so we'll keep keeping you up to date, but I thought it was interesting enough to share with you. Heidi, I'm thinking about skipping the next one for time and turning it back over to you now. Would that be okay with you?
Yeah, that's perfectly fine.
All
Let
right.
me, do you
We're
want to
flexing with time. I
advance?
do. And then you're going to take over for me. And we're going to
Yeah,
start here.
right there. And there we go. All right. Hopefully, if Lauren, can you give me a thumbs up?
I have so many screens open. Someone else give me a
Oh,
thumbs up so we can see Heidi's slides.
can somebody tell me if it's up? I think
Yep,
it
we can
Yes,
see
we
it.
can see it.
Okay, thanks, team.
Oh, I love the thumbs. Look at the thumbs.
Yay! All right, well, hello everybody. Welcome to the fall regional meeting. I'm going to be flying through info as per the usual. So what I ask is if you have questions, please put them in chat. As soon as I am done speaking, I will double back onto chat and answer all of your questions, I promise. So keeping with the GLP-1 theme, some big but unfortunate news and changes that are coming to NovoCare patient assistance that we wanted to make sure you're aware of. Ozempic will no longer be available to our patients with Medicare Part D. They are also going to be removing Ribelsis and biosimilar insulins. The biosimilar insulin's not that big of a deal, in my opinion. Branded insulins will remain on the program, except they're lowering the income threshold to 150% of the federal poverty level and adding an extra hoop, which is patients have to be denied the Part D extra help, which is a low income subsidy. And so they have to prove denial of that program to even enroll in the program. So unfortunately, this is going to make it more difficult for our patients. Sticking with NovoCares and Ozempic, if patients are uninsured, they will still be able to potentially be eligible. However, they are also lowering the income requirements for this as well. So in 2025, the income requirements were 400%. In 2026, a federal poverty level. In 2026, they're going to be 200%. Those income levels haven't been released yet for the year, but just to give you an idea, 200% in 2025 for a single person household was about 31,000, two-person household 42,000. So things to keep in mind. I know this is going to be a large impact on my practice, so we would love to hear from you. What percentage of your patients are getting Ozempic through NovoCare? I'm not seeing any results or progress on my end, so I just want to make sure it's working correctly. Oh,
Yep,
there
it
we go.
is. And I just shared the
Okay,
results, Heidi.
thank you. All right, so looks like a third are not sure, 40%, 10%, 20%. So, all right, it's not going to be as huge as an impact as I thought, but still an impact. I think there's still going to be some patients that need some help. So thank you for completing that for us. Um, let's see here. Let's advance. So what can we do to help our patients? I'm sure you're all aware it's open enrollment, and so we can inform our patients now that now's the time. They can call their insurance to find out if Ozempic will be covered in 2026, and if it is, what their out-of-pocket responsibility will be. And so they should be asking what their copay is. It can be a flat copay or it might be a percentage. And then depending on what they find out, if it sounds like that's going to be too much in the case of like a percentage copay, encourage them to go to Medicare.gov and start shopping around for other plans, and consider deductibles and premiums and whatnot. And I have some slides coming about that. And then also remind patients that they can spread out their prescription drug costs with the Medicare prescription payment plan that came up to be last year. And I do have a reminder slide coming up about that. So I included this just to give you a quick idea of how easy it is for patients. And so this is what Medicare.gov looks like. So tell them to look for this gentleman and click on the blue bubble in the corner that says Find Plans. It'll take them to the second page, which is this Save Time by Logging In. If they've already done this before, they can just simply log in. Do encourage patients to create a login because they can actually save all of their meds. This is especially important if patients are on several medications because they don't have to re-enter them every year. But that way they can search and see what's available to them year after year. Just wanted to give you a reminder that the coverage gap, the donut hole, is gone. So that doesn't exist anymore. Some plans do have deductibles. This year's max is $615, but there are lots of plans that do not have deductibles. The max out of pocket for patients across the year to pay for prescription medications is $2,100. That's $100 more than it was last year. But then keep in mind, after they've reached that $2,100, all of their medications are covered. These are the slides, so this one and two more that I've just included as reference. And so these are some facts and details about Medicare prescription payment plan and deductibles. And so I just wanted to include them for your reference in case patients have questions. So we'll be sending these out to you. But as you might recall, the payment structure calculation's a little complicated, so I included that for you. And deductibles are never easy to understand, so I wanted you to have those facts. So another poll question. I know this is a lot, and so we're always here to help you. So we have two questions for you. One, how comfortable are you in talking to patients about searching for Medicare Part D plans? The second question is, would you be interested in a one-pager that supports you in helping patients with this? I'm seeing people answer, so this is great. All right. Oops, you go away.
We're sharing the results with everyone, Heidi, so everyone should be able to see them, including you.
Um,
They may be covered by your screen. So we can say the Medicare Part D question, 11% very comfortable, 23% comfortable, 30% neither, 27% uncomfortable, 9% very uncomfortable.
And
The
93% of the collaborative wants a one pager.
Oh, good. Music to my ears. So I was kind of expecting that might be the answer, if I could advance my slide here. So we already started to think about this and want to always help you. So we've been working on this for a couple of weeks. So this will be available to you hopefully within the next week or so. But we're going to have a one pager for you with lots of resources for your patients to give them instructions on how to find out if Ozempic is covered, how to search for new plans. We even might be working on a little video to map them through how to do this online. So we will be helping you, and just know that we know this is a lot, and so we are there to help. Additional help. So the state of Michigan also offers assistance via SHIP, State Assistance Insurance Assistance Program. That was a lot to say. But patients can call this phone number, and there's a live person at the end of it via option 1. And when they talk to this person, agent, they can set up an appointment with a local agency, so different agencies across the state, and it's the type of appointment they are offered will be dependent on what area they live in and what their agency offers. But it seems like it's a great resource. It is free. It's offered through the state. And so this is yet another resource, especially if you have a patient that's just feeling overwhelmed by this process, which is understandably so. This is a free resource for patients. So definitely take a look at this phone number and bookmark that. Switching back to NovoCare. So these are some changes that are current, happened over the summer, and will be present through the end of 2025. You probably already are aware, but thought we'd go through it anyhow. Ozempic no longer is allowed to have auto refill, and then it's currently open enrollment. If by all those the changes in 2026, you still have patients that qualify, you can re-enroll them at this time. So let's focus on the Ozempic component. So auto refills not allowed. You have to fax in the refill request through this form. That's that website that's listed here on this slide. Now a little Band-Aid and maybe a little silver lining here. You can refill up to 120 days. So that means if you refill now or next month, you would get your patient through the new year. I've done this recently. It does work. They get the 4 months. It's a Medicare patient. So again, it might give you a little buffer to get them through. I do want to also give a little word of caution. On this fact sheet, page 2 is a long list of insulins. That's where the signature line is at the bottom of that insulin. I missed it the first time, and so my approval got delayed because I didn't see that signature line. So just wanted to give you that notice. The next thing is if you are signed up to actually receive a voucher, you're not getting the product shipped to your office for the patient. This is how the fax comes to you. And so if your office, we're centralized at Michigan Medicine, so faxes just come in, it's a phone number. Nothing on this cover sheet says NovoCares. It literally says voucher. Nowhere on here does it say a patient name. When you go to the second page, nowhere on here is there a patient name. There's initials and there's a date of birth. It then says a voucher number, which is extremely important because that's the key to patient getting their med covered for free. And then you can kind of see here, that's the initials. Then finally it says Novo Nordisk. It doesn't say NovoCare. And my office thought Cindy Pugh was a patient, so they kept trying to find that person. Doesn't exist. So this is now made up on a laminated poster for our call center to make sure these faxes get to me when they come through, because I'm generally the one sending them. So just want to make sure you're aware so patients are not delayed in getting what they need. All right. Also, hot off the press, we just finished our updated patient assistance guide for 2026. So thank you to my student Delina and Noah, who might be on the call, for updating this guide. But this is for you to help you assist your patients with the other patient assistance programs that we did not talk about tonight. Again, switching gears. Sorry, I'm talking so fast, but so many things to get through. So we're going to go on to our third pillar, CGMs. You have likely already heard about the Blue Cross Blue Shield decision to change the CGM policy in 2026. So, as of January 1st, patients must meet one of the following requirements. They must be on insulin, verified with a prescription claim. So, if it is at the pharmacy, it has to be within the last 365 days. If there is no prescription on file, then you will have to submit a prior auth, and the prescriber has to attest that the patient is on insulin. Patient can also receive a CGM if they have a diagnosis of type 2 diabetes and they have documented problematic hypoglycemia defined as level 2 or level 3 as outlined on the slide. I will not read these out loud. It's long, it's detailed, and all of these details have to be in your notes to get this prior auth through. Finally, another option, diagnosis of gestational diabetes with and experiencing postprandial hyperglycemia. Prior exemptions for MCT2D or PDCM will no longer be applicable, unfortunately. So, what does that mean for gold carding programs that have already been authorized? They are good for a year. So, that means if you had a patient who received their approval for their CGM, let's say June 15th of 25, they will receive that CGM through June 14th of 2026. It does also mean, unfortunately, that the Patient Empowerment Toolkit will no longer be available starting January 1st. So again, how can we help our patients? I think we need to take the opportunity that for many patients right now, it's open enrollment. So that does offer the opportunity for patients to sign up for health savings plans or flexible spending accounts, which can allow them to put money aside to pay for their CGMs if they choose to do so. I think it also offers an opportunity. Let's say they've been doing well on a CGM and maybe they don't need to wear one every single week, week after week. And you could talk to them about something that I've been talking about, a sensor holiday. And maybe they only wear one for 2 weeks out of the month. That will then save them some money because you're surely going to get asked, well, if I'm going to get this health savings account, how much money should I set aside? So I did a little bit of math for you. And so there's some options. So the blue bar are the Abbott products. The yellow are Dexcom options. The first one we'll look at is continuous use. So this would be 12 months of continuous use week after week of these sensors. And so we're looking at anywhere from $1,000 up to about $2,200 if patients are using a Dexcom G7. By far, the G7 is the most expensive option. The bottom row, if you're having any trouble seeing it, is the Dexcom Stelo, an over-the-counter CGM. The next option, the next column we'll highlight is if a patient were to use 2 weeks on and then take 10 days or 2 weeks off. So it's cut in half. So about $500 for the year or about $1,500 for that G7. The other thing to keep in mind for these patients is when their prior authorization is expiring. So, if you know when you sent in that prescription and it was in the summer, then they still potentially are getting 6 months of this, so they don't have to do a full 12 months. So I wanted to try to give a little bit of good news and something for you to share with patients so they can continue this. I've spent a lot of time just this week talking to people at Michigan Medicine who are employees because it's currently open enrollment at Michigan Medicine, and got a lot of positive feedback for the phone calls that I made. I do also want to point out the top row, that blue row, the $75 comes from this voucher. And so any commercial patient or uninsured patient, non-Medicare or Medicaid, can go to a pharmacy and get two Libre 2 pluses or 3 plus sensors every single month. There's no limit, for $75 per month. So that's where that $75 per month came, is via this. You don't have to carry these copay cards at your office. The pharmacies have them. They've been instructed to just bill this card if the sensors aren't covered. I included it just in case patients run into trouble, so you have the info. So switching our focus to another pair, just a small update for Priority Health, simply defining a max of 3 units of CGM supplies for 90 days. So this translates into 9 sensors for Dexcom, or 6 sensors for Abbott products. All right, so into the more fun, positive things, real updates about CGMs. So quick ask in regards to the Libre 2 Plus and Libre 3 Plus, if you can please spell out plus and not use the symbol. Apparently, some pharmacy electronic processors are dropping the plus sign. So when they get the prescription, they only get whatever Libre 2 or 3, and then the poor patient doesn't get their new sensor. So please write out plus. In terms of updates, there has been some new updates since we last talked about the new app at the spring regional meeting. So again, this should be the new app that you're making sure patients have. The Libre by Abbott, yellow butterfly and black box is what I asked my patients. And most recently, the update is under Insights. When they go to the daily report, they can run their finger along that daily line to see their actual blood sugar. So I tried it with a patient today, and she was like, "Oh, I didn't know this. This is cool." So just a new feature. And then there's also some accessibility features that have been added, and pertains to if their phone is set up in this manner. So if his phone is set up to be in Spanish, the app will also now be in Spanish. If the phone is set talk to text, the app will be talk to text. And then finally, just 2 quick reminders. Patients can silence the alarm. So this is important for, some of our patients that are not on insulin or sulfonylureas and are getting false lows. They can silence that alarm and sleep through the night now. And then the other thing I do want to remind is Abbott doesn't have a limit on replacement sensors. So we should be instructing our patients, if they run into problems, keep that sensor on, do not take it off, and call Abbott and talk to them, have Abbott troubleshoot. And then Abbott will determine if they're gonna mail them something and have the patient mail the sensor back, or if it's an emergency situation or something, they will send them to a voucher. But really let patients know that, Abbott is really behind their products and really wanting to get the sensor to the patient, not have them go without. So they should be calling Abbott to figure that information out. So in terms of Dexcom, we're still kind of waiting. I told you about this at the spring meeting. They had told us June sometime we'd see the G7 15-day. When I called them to ask for updates, there wasn't any. So I specifically asked about the 15-day, and they said, well, maybe by the end of the month. So, well, we're going to be there soon. So we'll see. We'll let you know as soon as we hear something. Also, I don't know if it's going to require a new prescription. They aren't just telling us too much. So I will keep you posted as soon as I hear something. And then finally, I want to just give a shout out. We've had 2 successful meetings for our MCT2D EMR group. We're sharing ideas across EMRs. We're creating creative shortcuts that currently don't exist in the EMRs by these conversations. We've created an EMR glossary, and soon we're going to have an email group so that we can share ideas and questions in our little group. So we meet about every 2 to 3 months, and we are currently seeking some additional members. So if you have the EMRs listed on this slide and would like to join our conversations and our group, please message Jackie during this meeting so we can have you join our next meeting, which is scheduled to take place sometime January, maybe February. We're not sure yet, but it won't be this year. So with that, thank you. Great to see you all. And I will start looking into chat for your questions, and I'm going to turn it over to Jake.
So we are going to talk very briefly here about some performance measure updates and just some quick brief reminders about the different primary care performance measures for 2025 to 2026. So to start out here, just some rationale why MCT2D has up until this point aligned fairly closely with the HEDIS measures that you guys are also working on. So just some key ideas here is that it helps with simplicity. Aligning across different quality initiatives makes it easy both for you guys and for us. It is very supported by our funder, Blue Cross, who also very highly prioritizes HEDIS measures. And then very importantly, data associated with HEDIS measures is much more robustly available than for quality initiatives or for labs associated with other initiatives that we may put forward, but may not be required to report via something along the lines of HEDIS. So just some background there. So for the first year of performance measures, you all should be very familiar with our A1C performance measure that we did from 2024 to 2025. So this is just some final outcomes of it. So you can see here that for commercial patients, we showed an improvement across the entire collaborative from baseline of 2%, with a total collaborative-wide performance average of 86%, which is fantastic. And then for the Medicare population, we saw an improvement from baseline of 1% across the entire collaborative, and that average collaborative performance was at 97%. And so 1%, 2% may not seem like a lot, but across the collaborative, it was actually amazing as what we see in the human impact. And so that translates to 417 or so patients that have went from uncontrolled A1Cs to controlled A1Cs, and 139 commercial or Medicare patients that went from uncontrolled to controlled just from this one small performance measure, due to all of the hard work that you did. So that translates to over 550 patients that reduced their A1C and significantly reduced their risks, meaning fewer medication adjustments, fewer meds, fewer ER visits, and a lot more patients with a lot less comorbidity risk. So great work, everybody. So 2025, what are our goals with the glycemic status performance measure as it relates to the 2025 HEDIS glycemic status measure? So right now, the description for the 2025 A1C measure is going to be the same population as it was last year for HEDIS, the 18 to 75. And the glycemic status rates, or the glycemic status A1C levels, excuse me, for commercial and Medicare will stay the same. So less than 8 for commercial and less than or equal to 9 for Medicare. And then we're still currently waiting on the target rate, so the percent of patients that are underneath those thresholds. That will be released in mid-November. And so that will be when we're able to share that out with you guys, and when we'll be putting that into the progress reports in the dashboards as well. So let's talk a little bit about what's changing between last year's A1C measure and this year's A1C measure. So what's the same? The population of patients that we're going to be looking at is the same. So still that Blue Cross Blue Shield, BCN, commercial and Medicare population, patients over 18 to less than 75 who meet that MCT2D criteria for inclusion in the data. So basically type 2 diabetes via either a diagnosis or A1C criteria. Obviously, we just talked about the pending. The pending is what that performance rate is going to be. That is going to be dependent on when HEDIS announces those rates. And then what is different? So the first one here is that there are no more aggregate groups. So each practice will be measured independently. That was something that was quite confusing for practices, quite confusing for us as a coordinating center, caused a disparity in the locus of control, and that certain practices were responsible for the performance of other practices within their POs. And so much more simplified, we'll measure everybody at the individual practice level. And then the locking of the population is also changing slightly. And so at the beginning of the last performance measure, the denominator was locked. No patients could be added to your patient population throughout the year. This resulted in significantly low patient denominators towards the end of the performance period because of patients' attrition between practices. They could drop out but not get added. And so we are allowing patients to move between practices up until the final 2 months, and then we will lock that so that you aren't held accountable for patients that join your practice in that final 2 months of the performance measure. All right, and so what does the timeline look like here? So the look back period that we used for the baseline reports to tell you where you kind of stood went from June 1st, 2024 through May 31st, 2025. And then the performance period, so for this current year's performance period, it ranges from June 1st of this year through April 30th of 2026. You can see here that that lock period, like I mentioned, is the final 2 months. So the population locks on that February 28th date. Importantly here, the measurement period spans this entire look back period through performance period. What this means, and you'll see this again on the next slide, is that if a patient is not seen again, they were seen during the look back period and then is not seen again during the performance period, for the purposes of final performance, we will take the last A1C that a patient had, and that'll be counted as their final performance. And so lost to follow-up patients or patients that are not seen during that 14-month period are still counting either positively or negatively towards final practice performance. All right, and so a couple more just quick details here. The rationale here behind limiting that to the final 2 months is that we want to make sure that patients that are joining your practice, like I mentioned, in the final 2 months of this period aren't being accounted for because your practice has a very limited amount of time to do any type of meaningful quality improvement or work with those patients. And so that's the purpose of keeping some semblance of a locking period. But like say, that locking period is only from the March 1st, 2026 through April 30th time period here. And then in summary, same criteria for the patient denominator as last year. And then the performance targets are still pending, as I mentioned. Patients with at least one A1C during that entire measurement period from the start of the baseline through the end of the performance will be counted, last A1C. And so that's just important. Keep in mind that a patient that does not get seen during that performance period, but was in your baseline and that you are seeing for normal clinical care will still count, either good or bad. All right. So performance tracking reports. So we have shared out with you the baseline reports for the new performance year. We'll be sharing out with you the progress reports throughout the year, and we'll show in just the next slide here the timeline on those. But this is what the new template is going to look like. This is just an example for A1C. There'll also be performance progress reports for the UACR measure as well. And that will be included in what is available on the MCT2D admin portal. And then the timeline on these. So as I mentioned, the baseline report was sent out in August. The first progress report will be sent out in November, followed by February, and then the final performance report for A1C will be sent in July of 2026. All right, so in addition to these progress reports, you're also always able to look at the MCT2D patient data dashboard. If you do not have an account, please reach out to me. I'd be more than happy to help you get access. The performance measures that are currently live there are still last year's performance visualizations. Those are in the process of being updated, and the new visualizations will go live in mid-November. So do keep an eye out for that on the summary measures dashboard. All right, so we're going to shift gears over to the UACR performance measure now. And so again, keeping this kind of in line with HEDIS. So we're modeling this based off of the KED HEDIS measure. And so that looks as with A1C at both type 1 and type 2. Obviously, our focus is narrower on just type 2. And then that KED measure requires both a UACR and an eGFR, whereas our measure requires only that UACR. And so we'll look at some of the differences here. So like I say, only UACR. This is a process measure. We're not focused on what the result of the UACR is. This is, did the patient have the test done during the performance period, yes or no? That is why we're focusing heavily on claims data, because it is a more robust and comprehensive view of this, whether or not that occurred or not. The rationale behind the 14-month performance period is to allow for a 2-month buffer period. This is standard of care for patients with type 2 to get a UACR done once a year. We have a 2-month period here to allow for patients to be gotten in. We know that you can't always bring a patient in the next 12 months or so. And then as with the A1C measure, this is again at the practice level, no aggregate groups. And then this measure also aligns with the performance measure for the nephrology participating practices as well. So there is some similarities there to align the initiatives across specialties. All right, and so what are the target rates here? So for primary care, the target rate is a 10% absolute improvement up to total of 90%. So for example, if you have a baseline rate of 72.03%, your target rate would be 82.03%. For practices that start above that 80% threshold, you only need to increase up to that upper limit of 90%. You don't need to go above and beyond that. And so just keep that in mind if you are already above 80%. The baseline period was from January 1st, 2024 through February 28th, 2025. Those baseline reports were distributed in May 2025. The measurement period goes from that July 1st timeframe through August 30th of next year. That's your 14 months. And then it's important to note that because this is a process measure, did something happen during the performance period, every practice starts at 0 for the performance rate. And so the baseline rate is to give you an idea as to where your practice is and to set your performance rate for the following year. It is expected that every practice will have low performance in the early portion of the performance period because this is a process measure. And so just don't be surprised by that when you get your first performance report and it says that you're not meeting the measure and that your performance is 20%, for example. That is expected. Keep working towards getting all of those patients seen for your UACRs. All right, and so this is also a tiered point system. So for this performance measure, if you hit that 10% improvement, you get all 100% of your points for that scorecard item. If you improve between 7.5 and 10, you get 75 or 9.99, you get 75% of the points, so on and so forth. So there are 5 categories of point distribution. So this is not an all or nothing like the A1C is, which is a did you meet it or did you not meet it? So this is a tiered percent improvement point system. All right, and so report template timeline for the UACR measure differs ever so slightly from A1C. And so we do have that first performance report coming out in November as well. And then second one in March 2026. Third one, which is actually report 4, report 4 coming out in August 2026. And then that final performance report at the end of the performance period will be in February 2027 with data due to July in July 2027. All right. With that, Dr. Oshman, I will turn it back over to you.
I think I did it. I really loved the thumbs ups last time, so wait for some more thumbs up. So one of the things that we're hoping to do for the collaborative is to try to give you as many benefits as possible for participating. So I have good news for family medicine and a wait and see for internal medicine. And that is that we have our UACR improvement measure approved for ABFM maintenance of certification credit. So if you're recertifying and you need to submit your documents by the end of December and you've participated in this measure, you are able to submit this for this calendar year or next calendar year, but not both. And obviously we can recycle this with other improvement programs over time. I will leave this information for you for reference, but essentially this is for board certified physicians, not our NPs or PAs. And the internal medicine certification project is program is quite different. We will have you sign an attestation, really just that you reviewed your data progress reports, which is what we want you to do anyway. And then we are going to submit that on your behalf. And so that can start following the distribution of the November progress report. We will talk after the meeting about how to get that information out to people, but probably we'll just send you a reminder kind of December 1st-ish to put that back on everyone's radar. So thank you, Jake, for all of the excellent information to ground everyone about why we chose UACR, why it's important, how we're measuring it. Now we want to talk about how to improve. So we did some surveying, and we did this survey in May 2025 as part of a year-end VBR option. So this isn't everybody, but this is 114 collaborative meetings from 22 of our 24 POs. And almost all of you have some sort of system to track UACR screening. You're using a variety of different strategies. Some of you have an EHR alert. Some of you are doing manual tracking, registry reports, or other. But most of you feel like your system is effective. If you look across the board, most of you feel like whatever you're doing is effective or very effective. So we also asked you about barriers and what are the practice and workflow barriers that you experience. And for those of you who don't have a pop-up reminder or practice alert, you're identifying this as an opportunity to improve. We've got some struggles with the lab not completing the right test. We've got some struggles with urine test collection not being available in the office. And, you know, when you mention other, the people issues, right? Having the workflow, time, and resources to do this, and training all of our staff and physicians and providers about the importance of UACR testing. Who is managing this at your practice? So we asked you who's responsible for managing UACR screening, and you answered mostly the PCP. The second most common answer was shared responsibility, followed by the medical assistant, a care manager, or others. And then we asked you about having this practice alert or prompt pop-up reminder, however it's built into your EHR. About half of you have this method, and about half of you don't have this. or are not using it consistently. So what about patient level barriers? I think this piece of not being able to collect testing in an office is really something that is important and may require some advocacy for us, depending on rural areas or hospital affiliation. And this certainly mirrors your system level barriers. Downstream with that, maybe you have an external lab and you're not getting the data back into your EHR. Maybe patients are having other social determinants or other struggles getting to the lab. But there is this piece of patients not understanding why the test is necessary. And I really do think that that is something that we can tackle. So you had ideas. What ideas do you have about increasing UACR testing? And we asked you so that we could develop some tools to be helpful. And this includes educating patients on why we're doing it, and also educating physicians and providers, optimizing your workflows, whether that's chart audits, reminders or alerts, scrubbing charts, or pre-prepping for visits, patient engagement, leaving that sample if that's available to you, thinking about in-house or on-site capabilities, and then making sure that we're able to follow up on care gaps between visits. Frequent testing and follow-ups, again, for some patients, they may be getting a UACR test slightly closer together than 12 months, because otherwise it would be 23 months until their next test. So we asked you in the registration survey today, so now this is everybody, what your practice is already doing and what you want to start doing and what you're not interested in, so we can help you the best. And you can see what you're already doing here in the dark blue, what you want to start in the light blue, and what you're not doing in the yellow. And you can appreciate that most of the energy around things you want to start doing is using MCT2D's data dashboard and our handouts, doing some outreach before the visit, improving staff training, etc. So I am going to have another poll launched here, and we're going to open this up. We haven't done a poll in a while, so get ready to engage again. And we're going to ask you, do you do on-site collection for urine at your practice right now? And I will specify urine for UACR, not just any urine. Urine that you can either test in-house or send out, but are you able to get the sample on site? All right, we got 123. See if we can get another 10 folks, and then we'll end the poll. All right, it looks like people have stopped responding, so we'll end poll and share those results. It looks like 82% of you have the ability to do on-site collection, but I think that's really important, right? 17 of our practices want to do this, and 7% don't plan to. So moving on, at least half of you are already doing these items, and this is information I already provided. Many of you want to start using some handouts, monitoring our dashboard, doing some staff training, and reviewing your team's gaps in care. So we have created some tools for you to get started. You can scan these, but I promise we'll give you the handouts before the end of the meeting. So we have some physician and provider and team member training and awareness resources that were developed with our nephrology team about why it's important, what we're testing, and how we're using it. And then we have some performance tracking opportunities and the baseline reports that we'll share with you in a little bit. You're mixed on patient outreach. Some of you are planning to reach out to the patients before their visit. What if someone pees before they come in? That's always annoying. Some of you want to order that UACR at the first appointment of the year, and some of you want to add new EHR results. So with that, I am going to invite our three presenters, Dr. Alof, Dr. Kabir, and Shirley Cardinal, to get ready to present. And Dr. Alof, if you can come off mute, I'm going to run your slides for you. Let me know
Great.
if you're, thanks.
I'm ready. Can you hear me okay?
Yes,
Yay.
thank you so much. Introduce yourself, and we're so excited to hear about your practice.
Hi there. I'm Jennifer Alof. I am a family physician in Midland and part of the Great Lakes Physician Organization. Our practice, like I said, is in Midland, Michigan. It's a suburban area, headquarters to Dow Chemical, but a town of about 50,000. So we had been on the Allscripts Pro EMR for about 14 years, and then this spring undertook the adventure of transitioning to a Prima in May of 2025, which presented some interesting challenges and opportunities. I am currently the only physician in our practice. We have 3 nurse practitioners, 1 PA, and 2 RN care managers. Like I said, I'm in an independent practice. We do have a CLIA waived lab, so we do urinalysis, we do hematocrits, we do have a lab standard A1C machine, so we do finger poke A1Cs in the office. And then we do urinalysis. I think I said that already. And we have a total patient population of about 5,200 patients. Next. So we had 120 MCT2D attributed patients, and our baseline performance was at 91.67%, I'm pleased to report. So what do I think are our real keys to success? The team-based data-driven workflow is the number one thing. It doesn't rely on any one person making sure to capture all of these. We have a multi-layered approach to making sure that everybody pulls together to try and catch the people who are falling through the gaps. We work hard to try and address any barriers to patient completion, and then the in-office collection of the urine sample at the time of office visits has been really crucial to closing our gap list. And we'll go a little bit more into detail on these as we go forward. Go ahead. So we'll talk a little bit about the team-based process. We do have an annual flow sheet for all of our diabetes based quality measures, and there's a copy of it at the end of my slide set to give you an example. But it does include the urine albumin creatinine ratio, lipid panel, retinopathy screening, their A1C, do they have treatment for diabetic nephropathy, and other diabetes or non-diabetes care measures such as their cancer screenings, immunizations, etc. So before each office visit, the MAs do go through and prep each chart, looking back at what labs have been done. They record both when these metrics have been completed and then when were they coded last. So we're making sure we're capturing not just the completion of those, but coding the F codes to make sure that those are being documented within our office notes. And we do have a rolling reminder system where we will put a note in the chart when the next screening may be due. So we do have actually a quality manager who goes through, we use a patient registry called Health Focus, which is one that is provided to us through GLPO, and we use it for managing not just diabetes quality measures, but across our ACO and our value-based care payments. We can use it to look at claims, and it's a very, very robust tool. And so she works the gaps list, and we'll put a pop-up in the chart when a gap is outstanding for that specific patient. So that's an additional reminder for the medical assistant and for the provider, because it'll be facing both of us when we see the patient. And then the thing that, going just back, the thing that really boosted our performance from the 80s to the 90s was when we made arrangements with Quest to start obtaining our urine albumins in the office and sending directly to Quest via pickup. So patients who haven't been completing it at the lab, we can capture it right there in the office. Go ahead.
There we go.
Thanks. So we just talked about the flow sheet, and like I said, we'll have an example below, and then Health Focus, which is really a robust patient registry. And there were some increased challenges for us when we transitioned from Allscripts to a Prima. So we had a built-in flow sheet for quality measures in Allscripts, which we haven't yet quite figured out how to implement in a Prima. I think they do have what are called clinical decision rules built into a Prima. So I think once we have been on that tool for a year, we'll be able to build those in, or maybe with the next calendar year. So that's something still to come, because it would be nice. We are doing it now. the MAs are pulling a paper flow sheet, so it's not as efficient as doing it right there in the EMR. So this is an example, and the first column there on the left would be the last, when it was last completed, and then the right column would be when it was last coded. So you can see that those are kind of the things that we have been tracking, including their foot exams and do they wear diabetic shoes. If they do wear diabetic shoes, then we know that the physician has to provide the diabetic foot exam. Otherwise, the nurse practitioners or PA can do it. Are they on a statin is another thing that we are tracking regularly. And then when the roomers room the patient, we actually have a set template that they use to track what things are outstanding. So it'll say right on there, when I go to pull the patient's chart, patient is on a statin, has their eye exam and A1C and urine microalbumin are up to date, and they need a foot exam today. And so that's very helpful. Our RN care managers, if we have specific patients that are having barriers, we can arrange home blood draws, or they can help with transportation to help patients get to the lab, maybe interface with family members to coordinate care and make sure if patients aren't understanding, especially in our geriatric population, getting their labs done ahead of the visit so that we can more effectively communicate about their results. Then our RN care managers will work with those patients to help them. Our clerical staff, as we said, maintain our gaps in care list and monitor health focused population quality measures. Medical assistants are really integral to keeping the providers on the straight and narrow path. And then sometimes the providers do sometimes find things, like we just realized, as Lexi, our coordinator for MCT2D, and I were discussing this meeting tonight, we realized that when we were making the transition to our EMR, some of our lab results were being scanned in as documents because we weren't getting discrete data flowing. So now we have to remind the MAs, don't just look in the discrete data, you got to go check the scanned documents for labs too, to make sure that they're not duplicating orders. So there's always critical thinking at every level of the team. And then the providers, of course, need to act on any abnormal findings. So our biggest challenge was we were sending out labs on a consistent basis as part of the chart prepping process. And the MAs were calling patients and saying, hey, you have an appointment next week. We need to make sure you get your labs done. But then patients were saying, oh, I didn't realize, or I went to the bathroom right before I got to the lab and I couldn't go. So we started doing on-site. And it was easy for us to arrange with Quest because we already had an existing relationship with them. In that we were sending in urine cultures and they do our pathology samples for biopsies and whatnot. So it was just a pretty straightforward thing to develop a workflow and just augment that to what we were already doing. And then like I said before, if we can't get the patients able to do that at home or, in the office, then we have been able to arrange some home draws. And I'll just give you one example. Like I had a patient that I saw just last week who's in his 70s. He's a well-controlled diabetic, and we share care for him between the VA and our office. And we're able, he gets his annual labs with his lipid profile and his, comprehensive panel and CBC and whatnot at the VA, but they don't do a urine for microalbumin and creatinine ratio. So we were able to obtain a sample right there in the office. We already had done his A1C right there in the office. So then we were able to close the measure, and he was happy to give the sample. He's like, great, I don't have to go to a separate lab. And he was really pleased with that. So that works out very well for those patients. We've also had patients who were like, I can't, the lab closes at 4 and I work till 5:30. I can't get to the lab. And so we've told them, hey, we're open on Saturday mornings. We'll give you a bottle. If you drop it here to us, we'll get it to the lab. So there, we just label it ahead of time. We have the lab order ready to go. And so having the in-office lab accessibility has been really helpful for closing those gaps.
Dr. Aliff, I'm making furious notes. Take home pee bottle. We're going to save questions for the end. And I'm going to position us. Thank you so much for sharing the incredible things your practice is doing. And I just want to appreciate, not everyone likes public speaking. I very much appreciate all of you agreeing to do this tonight. So Dr. Kabir, if you're available, see if you can come off mute.
Hello, good evening, everybody. Can you hear me?
We can.
We can. Oh, perfect. That's great. So I'm Abdul Kabir. I'm an internist. Our practice is located in Monroe, Michigan, which is a blue-collar town. City has a population of about 60,000, counties 150,000. Uh, we have one hospital in the county. That's the only hospital. And all the labs are done at the hospital. We used to have outreach lab in our office, but after COVID, it closed down. So all our patients go to the hospital for blood work. Our EMR is eye patient care. We have had eye patient care since the beginning. I think around 2008, 2009 is when we got it. I am independent, solo practitioner. I do have a PA and a nurse care manager. And then we have medical assistants and support staff. Our patient population is about 40% is commercial, 60% is Medicare Advantage plans. If we can go to the next slide. So we have about 240 patients in MCT2D, and we have a capture rate of about 95% on urine microalbumin. Next slide. So keys to success. I mean, I think for us, as a physician, buying into the program and believing in it, and then educating our staff, and staff involvement and staff engagement is the key. We have EMR that tracks all the measures and flags it in red. So basically, MAs do all the heavy lifting and day-to-day work. They go in and pre-populate the chart, and they order all the tests that are highlighted that need to be done. So by the time I get in, it's already done. So can't take credit for doing all those urine microalbuminurias. So it's basically the workflow. Then at the back end, we have EMR has a built-in registry, so we can add things, remove things, and it can track things. So at the end of the year, we do run reports and then do gap closures and outreach. And my care coordinator is the one who tries to get it done at the last minute. Then we also have MAs and front desk that we give lists to that do the call outs and reach out to patients. So basically, it's a team approach. As far as patients are concerned, I mean, they do ask why you're doing it. Recently, we started doing urine microalbuminurias for hypertensive patients too. So they're the ones who question, like, you never did this before, why are you doing this now? And usually it's the MA that gets that question, and she tries to explain them, and then I come and I reinforce, and we don't get too much pushback from patients. Next slide. So that's pretty much the same, that everybody is proactive and do outreach. For barriers, I mean, the biggest challenge as a solo practitioner, independent physician I face is staff turnover. You teach somebody, they start doing what they need to do. The system is like the whole office is running smoothly, and then you find out that one person leaves, and then you get somebody else, and getting them on board, educating them, and by the time they're performing, it's like 6 months, you're 6 months behind, and all your quality scores are down in the gutter. So that is the biggest challenge that we face to when there is staff turnover. I mean, we don't do urine microalbumins in our office. We send them to the hospital. We never had any issue with that. Um, Patients, again, if you explain them in simple terms, like why you're doing the test. I mean, what we say is like the blood test does not catch kidney disease till much later. But if we do this test, we can pick up kidney disease in much sooner, and we can do some interventions to make sure that you don't end up with kidney disease. And once you explain that to patients, they pretty much are okay with doing it. Social determinants of health do matter. I mean, obviously, um, depends on your social, I mean, level of education of patients, their profession, whether they have insurance or they are uninsured, all influences, lab testing. Um, Next slide. So as I said, like, our staff does a lot of work around this. And I mean, as a physician, I don't do much of the heavy lifting. Sometimes patients do question why you're doing this. Would my insurance pay for it? And I usually say, yeah, it's covered. Your insurance actually wants it done. Uh, so, so we don't get too much pushback on this. Next slide. And we just talked about that cash paying patients would have a challenge, and but otherwise, I mean, I think that most people just comply. Next slide.
That is your last slide.
Okay. Well, so
All
that's
right, I'm
about
gonna
it for me.
mute you for now because I'm getting some feedback. Thank you so much, Dr. Kabir. And I think it's just interesting to know that your practices are across the state in different areas. And we didn't mean to select only independent physicians for this presentation, but just to appreciate how integral and hands-on your staff and teams are. So Shirley, I'm going to call you Dr. Cardinal, but I'll call you Shirley.
No.
Go ahead.
Okay, hello. My name is Shirley Cardinal. I'm an RN care manager for Dr. Grimshaw. I work for him 2 days a week. Next slide. So we're in Birch Run, and it's a rural community. Epic is our EMR. So it's Dr. Grimshaw, and we have a PA, Megan Dennings, and then myself for 2 days. We have 4 MAs. We've had staffing issues ourselves, and we just recently got our 4th permanent staff, and we've had a lot of temporaries. We are employed with Covenant Medical Group or primary care partners. On-site lab, we do not have one. We do on-site urine collections. Our patient population, we have about 2,240 patients. And with the Epic, I was able to run the high risk, low risk, medium risk. Our high risk population out of that 2,240, it's about 170. Medium is about 290, and then the low is almost 1,550. So we're able to, I pull reports on those risks too. So go ahead and next slide. So the advantages of Covenant's Epic is it's robust. It does so much for us. We are able to pull reports from our dashboard, ensuring that we are aligning to our HEDIS guidelines. So we have several built-in tools within Epic. We've got registries the registry, as soon as you are diagnosed with diabetes or pre-diabetes, your name or a code goes into that registry. With that registry, I'm able to see your last appointment, when's your next appointment, what's your risk score, and really honestly, what your A1C was. So that registry helps me immensely pull reports. Like we don't have, I can look at that registry and pick out who needs an A1C. Care gaps monitoring, same thing. The care gaps, we have a thing that we call, what's it called? Dashboard, or it's the like a snapshot, and it's on the side, and it's everything is in red. So if you have a care gap, it's in red, and it tells you need an A1C, you need a physical, you need a colonoscopy. So our MAs, when they're prepping charts, that's exactly what they're looking at, and they're pulling all their information into the chart prep for the doctor, setting up the orders for the UACR, A1C, anything that they need. Lets them know if they have to have a colonoscopy, if they've had their mammogram. And then we have a patient advisory set up on Epic that our physician or whoever's in the chart for that appointment, they cannot close out until that's been addressed. And then the smart sets are like our dot phrases. Our MAs are essential with their smart phrases and prepping the chart, and they have their own little setup and their verbiage that they use to prep the chart. So Epic has given us so many tools, and especially me as the care manager, I have so many places that I can look at data. Next slide. So with ours, we have 106 attributed patients and a 91.51% rate. Next slide. So the UACR screening success, it's consistent proactive patient engagement. What we do with that is beginning of the year, and of course our dashboard resets at the end of this year. So everybody's got a brand new slate. We are front desk MAs before the appointment. Either the back or the front desk will have called them and said, we see you don't have your lab. We need you to get your labs before you come in. Consistent proactive patient engagement is exactly what we're doing. Constantly reaching out to patients to let them know that they need their labs drawn. If they can't come in and get their labs drawn, or they haven't been able to urinate when they get the lab, we do the draw right there in our office. Next slide, please. So this is my Epic dashboard. It's a snapshot of what I see. So I can sort based on the eye exam, whether or not they're in the 8% or 9% A1C control, their kidney health evaluation, if we've had eye exams. So I can sort through all of this. And then as we enter the data, we're able to see the percent go up. So this is all based on our HEDIS measures. Also, I use this for possible care management referrals. I can look at risk scores on this dashboard, see who's a high risk, low risk, medium risk. So I get a lot of my referrals just from this. I also use a collaboratively with the MCT2D dashboard. That dashboard tells us a lot of information, of course, but between the two, I get a lot of my own referrals right from there. Next slide.
Oh, went too far. Go ahead.
So I also use the PDCM report. Now this PDCM report is from Blue Cross Blue Shield. This comes out every 2 months or so, and it's got data that's old. It's about 3 months old, and this is based on claims. So at the end of the report, you can see that the categories, the BN, is their CKD clinical risk. So you can see that it's at risk and there's a moderate risk. I can look at this real quick when this report comes out and see if there's anybody new that I haven't addressed. I don't know all of our patients, but I like to try to find them, the most of them, if I can. So I do use this report. Now, the next one is BN, the severity. This report tells me if they're high, moderate, based on their claims from Blue Cross Blue Shield. The next one is the BT, which is their severity of illness. It tells me if there's been any change since the last report. And then the BU is anything additional. Now, I also use this report to do my advanced care planning. Or, discussions with patients. I can look at this report to see if they've actually got advanced care planning. This also ensures the appointments are made with the PCP and that we've got the appropriate labs. So it's a report I don't use often, but I do every time we get a report, I look at this information. Next. So we do nephrology referrals. We like to, take advantage of our nephrologist. Dr. Grimshaw will send a referral to Dr. Zaharik. She's a nephrologist. We also refer often to the kidney and hypertension consultants in Saginaw. Or if a patient already has someone in mind that they want to use as a nephrologist, we refer to nephrology if a GFR drops below 30 or if there's a rapid fall in GFR, he will send to a nephrologist. Go ahead, next. So our process for success has been, start of the year push. You begin ordering the UACRs, the A1Cs, the labs for a diabetic patient, first appointment of the year. They never leave without another appointment scheduled. Very important that you have that next appointment scheduled. The front staff, they check the labs for the appointment, like I said earlier, notify the nurses and care managers if it's incomplete. I peruse the schedule beforehand, usually the day before. I already know if I'm going to get a referral from doctor prior to me getting a referral usually. Like I said, I'm only there 2 days a week. So I reinforce with the team reminders, calls ahead for appointments. If I notice when I'm calling a patient ahead of time, I'll look to make sure there's labs in there. There usually are, but there has been times where, especially when we've had staffing issues, where maybe a lab did not get ordered, and I'll facilitate that getting in. We do the in-office collection. So if we notice that we don't have the UACR, we will get that lab done there. And then the EPIC population health dashboard, that has been so big for us getting our testing done and compare against our schedule. Next slide. So tracking and data use. Of course, I use the EPIC population health dashboard and the MCT2D dashboard. If you're not on that, I highly recommend that you get out there on the dashboard. Lots of great information. I check upcoming appointments again against the dashboard, PDCM, serious illness, and CKD slots. We use the reports for physicals, A1Cs, the annual checklist, like I said, mammogram, colonoscopy, and then the proactive referrals to our nephrologists if we need. Next slide. So the team role and coordination, our front desk staff, they do check in, check out. All four of these staffs are doing referrals, prior authorizations, patient assistance, you name everything that they're doing in the office. Plus, they're also doing these pre-visit lab checks and reminder calls. If a patient cancels, they can cancel their appointment on Epic, and we get notified that it's been canceled. They're making a phone call quickly to get them rescheduled. So we don't, our MAs are what we call our nurses. We do a lot of in-office collection, our patient education. Care manager, I do the dashboard monitoring. I also see a lot of our diabetic patients. So I will also talk to them about the importance and what the UACR means. Our manager, she pulls reports. She's coordinating with the front desk and the team to get gaps in cares done. We're doing a lot of that right now, pulling reports, making sure that we have the physicals and colonoscopies and eye exams. And then we have a wonderful community health resource partner with Epic who takes care of our SDOHs. So that's one thing that's off my plate, and that he takes care of the SDOH and then gets a hold of me on whatever else there could be, or maybe some needs that I have to deal with. Next. And so our challenges have been staffing. We have non-compliance with labs. We try to call them and bug them actually to get in there and get it done. After a while, they know they just have to do it. We have a lot of patients that are not using Covenant Lab, they're using the Quest. And so we have to make sure that we ask that question ahead of time and that they have the orders in hand. We also send them out to them before, call them, make sure they have the orders, and then we send them out to them. So that's a little duplication of work, but we're getting the urine done. Transportation difficulties, that is huge. We just recently had a patient, he's not a compliant diabetic. He uses Medicaid transportation, has a lot of barriers and issues. And the transportation stood him up at a 4:30 appointment. So then our staff is trying to find him, calling family, doing whatever we can to make sure he gets transportation home back to Saginaw from Birch Run. And then the lack of on-site lab services, but we also use the external labs however we need. But collecting urine on site has been, for the UACR, has been very implemental for our health, for our clinic. Next. I think that's it.
Really, thank you
I
so
talked
much.
really fast and I'm sorry, but thank you.
I just think across these three practices, I have a whole page full of pearls that I'm taking away, and I just really appreciate that. Heidi, I'm going to ask you, is there anything in the chat, and maybe we'll pick three questions and then move on. Do you see anything that's particularly
There
pertinent?
wasn't a lot of things have been answered, and I think it was more about like measures. I guess I would like to give the opportunity if anybody wants to ask our speakers any questions, they can certainly unmute and ask.
And
So
while
I'll
you're doing that,
pause.
I just have a question, and this is for anyone. When in the year do you start, like, patients have a year to get their UACR. Like, how do you make sure you're not getting ahead of when they have an appointment and deciding who to reach out to?
And Lauren, this is your 7:28 time notice that you asked for.
So for us, it's a rolling year, right? So with our flow sheet, we know that it was in April, so it'll be due in April. So if they're there in February, we'll give them a lab order for April, and then if they show up for their March or their May appointment and it hasn't been done, we might grab the urine, might grab them in right there in the office. So we kind of, because the flow sheet tracks when it was done last, that's how we know. I did get an interesting, a direct question that was, how do you get the level of staff engagement you get? And I will say that we directly incentivize our staff, because as we earn pay for performance money in my practice, that gets shared with the staff. So my philosophy on that and my former partners was always that, if we couldn't get this job done if the whole team wasn't pulling to do the work. And so we share in the incentives with our staff, and that's why they're all motivated to help us achieve these goals.
Dr. Kabir, if you want to unmute, anything else to add or other wisdom?
No, I lost the internet connection, so I couldn't hear the response. But I think your question was, when do we start doing it? So we start doing it January 1st, and then we just keep doing it the whole year.
All right. Well, I think I'm going to move us along because I did get a warning that I asked for. Anyone who wants to use to make hearts or appreciations or claps, please do. Those are always fun to see float in the screen. And I'm going to move us along to our last few parts of our presentation. So there's a lot I want to disseminate from the best practices that we've heard about. I think particularly in my practice, thinking about home nursing, UACR non-completion is very likely an indication that this person has something else going on in their lives, and there may be ways that we can help them. I know Medicaid transportation will transport people to the office and the pharmacy. I think maybe also to a laboratory. Maybe there are some things I'm not thinking of. And so how can we support you? We're going to, continue to provide more and more support to you to make sure that we can make sure that 10 out of 10 of our patients are able to have their UACR testing done. But here's some specifics that we've already started working on. So just to reorient everyone, and I think another takeaway is that we are happy to do dashboard tutorials. And I'll take your question at the end if that was a question. And so as you're going onto the MCT2D dashboard, you're going to select the legacy patient dashboard and you're going to go to renal details. So just this is a little bit hard to find, orienting you to where the UACR information is. And then you're going to go to filters and then you're going to go to the UACR as you can see on the right. And so we'll provide this information to you, but making sure that you know how to find the information on the dashboard. And then again, we have already started by providing some information for patients, but also for staff and providers and physicians focused on UACR screening. You just heard about best practices. We are partnering with the National Kidney Foundation of Michigan. So if there are any practices here who are really struggling with just having the manpower to do QI and find out how to improve on this measure, we have the opportunity to have some of our practices have a quality improvement facilitator work with you. And so we'll reach out to you about that later. And then obviously we're going to continue to share your quality progress on this measure. So I am going to turn it over to Laria.
Thank you so much, Dr. Oshman. This has been a really great meeting so far. I love hearing all those other presentations from the sites. And now I'm really excited to have an opportunity to share some updates on some of the things that our team has been working on related to our pre-diabetes initiative. Please feel free to put questions in the chat if you want as I go, and I'm happy to respond to them afterwards. But first, before I start with the update, I wanted to kick us off with a quick temperature check and ask how confident are you feeling at this moment on a few topics related to prediabetes. So you should see a poll now on your screen, and that's going to ask you to rate your confidence on your current care at your practice, that your practice provides patients with prediabetes, the resources you have to successfully refer patients to a DPP program, the resources you have available more generally for diabetes prevention, and lastly, on clinician understanding and the importance of supporting patients with prediabetes. So take a moment there to fill that out and just know that you will have to respond to each of those statements in order to hit the submit button. And Jackie, if you can let me know when you feel like it's a good time to end it, that would be fantastic.
Yep, sounds good. I think we should give people about maybe 15 to 30 more seconds. The answers are coming in, but since this is a little bit longer of one.
Longer what? Perfect, thank you.
We have 100 people who've made it to question number 4.
If you're on a mobile device and not seeing a poll, you may just need to slide over to the screen to the right.
And please feel free as well to put anything in the chat. All right, thank you so much, Jackie. So thank you for doing this temperature check. I'm just looking to see how confident people are feeling. It looks like a little less confident on having the resources needed to address diabetes prevention and target prediabetes than some of the others. So I'm hoping we can, through some of the resources I'll share with you today, hopefully provide you with some additional ones to help with that. And again, we'd love your feedback as we go through this process of developing our new initiative. So I just wanted to get started again. Moving into this update, we're so fortunate to really have a lot of rich information that you've been willing to give us over the past year or so through some of our different touch points we've had with you on prediabetes and what you see as the gaps, what you currently do, things like that. And this included conducting 2 focus groups, some surveys, a collaborative wide meeting activity, and other interviews. And your participation in these activities allowed us to identify some key gaps that we felt like we could start addressing. So some of these things were telling us that DPP is only one option and that you really wanted a menu of things that your patients could choose from, that patient motivation, education, and knowledge was a big challenge, that the practices needed specific screening criteria and have a standard definition of prediabetes, that you needed assistance with things like billing and coding and making sure different things that you could offer patients like nutrition counseling was reimbursable. That DPP content is not always good and can sometimes be bland, and that patients need resources that resonate with them on a personal level, and that you needed help with more consistent and streamlined workflows. So we took these key takeaways and all the other valuable information that you gave us, and we used it to identify 4 areas and activities in each of these areas that we as a collaborative felt like we could start working on. And so these areas are clinical process, awareness and education, data and tracking, and coverage and access. And we're really excited to have started working on many of the activities underneath these areas, and plan to expand and develop more in the coming years. But today I'm going to share a small update on the support we're working on for screening under our clinical process area and exciting developments on our patient and provider awareness and education area. So many of the collaborative members told us that you really needed help with clearly defined screening guidelines and by providing that clear definition of prediabetes. And so in response, we created this MCT2D prediabetes screening guide. So as part of this, it does provide that definition, that A1C range for prediabetes, as well as the screening test options that are consistent with prediabetes, screening recommendations, and additional information on things like billing codes and what's covered in terms of screening frequency. So this resource is available now in the resource library, or you can access it by scanning the QR code on the screen, or you'll have access to the slides after these presentations. And then next, building off our Jumpstart Low Carb model and some of the other tools we had built, we decided we wanted to build a one-stop shop educational hub for all of the key content and information that we were curating around prediabetes for both patients and providers. And so I'm going to be showing you some sneak peeks of what this website is going to look like, but please know that this is in development and subject to change. And like I said, we're really excited to gather your feedback and continue updating it from there. So on the patient side, this website will include a clear call to action for patients to take initiative in their health, information on topics like metabolic health and prediabetes, how to interpret and understand labs, things like that. And the MCT2D design and informatics team has been developing this content with our content experts led by the fabulous Dr. Jonathan Gavison, and also with guidance from our patient advisory board. So we've really tried to get their feedback, and we'll continue getting their feedback on the sort of language we use and how we invite patients to take action in their care when they receive something like a prediabetes diagnosis. This website will also include a menu of treatment strategies. So going back to your comment about really wanting a menu of things to offer patients. So this will include things like DPP, nutritional support, physical activity, CGM, medications, and more. And this menu is really meant to help patients select those strategies that they want to try and identify next steps that they're interested in engaging in. So this site will also offer provider information on these same strategies so that we can make sure that that's easy and readily available for you, and include additional support, again, on that provider-facing side for things like coverage and coding. So patients will be able to access these strategies as topics. So if you want to encourage them to check something out specifically, they'll be able to access this information. And they're also going to be able to use something that right now we're calling a matchmaking tool. And you can see how this might look on the final website here in the bottom left-hand corner. And we really wanted to create a way to help patients navigate all of this information and identify those strategies that might be a good fit for them. And so our team has been designing matchmaking tools, what we're calling it right now, for both web and mobile that will help patients identify the next steps in their care that they are motivated to try. So we hope that they can then take this information and share it back with you, with their care team and with other supporters in their life to help start implementing some of these changes. So on the left, you can see a mock-up of a version that will allow patients to select strategies that they're interested in learning more about and use that to generate a custom page with additional information about those strategies. And then on the right, you can see a mock-up of a version that functions much more like a quiz and asks the patients to to answer a few questions about things like their health goals, barriers, learning preferences, before sharing some of those recommended starting strategies with them. And again, all of these recommendations, once they've been generated by the patient, can be saved and shared. So each of these strategies, and you can see here a mock-up of what the diabetes prevention program example might look like, will each have a landing page that will include much more detailed information, give an overview of what that strategy is, talk about the health benefits, how to get started with that, and also provide additional interactive resources that we really hope will help patients take the next step. So in the DPP example, this might be something like a program locator, or could be links to something like Silver Sneakers program so that patients can access that as they learn about physical activity and the impact on prediabetes. Things like our low carb recipe generator and allowing patients to generate really individualized recipes that fit with their culture and preferences. And we're building out this content. We really want this to be a helpful hub. So we'll be asking you a few questions in the post-meeting survey to share information, one about DPP programs that you use, so that we could potentially include it in something like the tool you see here. And also if there's anything else that you want to see in a tool like this. And lastly, here you can see an example of the provider-facing content that we would include. So that would be things like that screening information that we talked about on the tool that we have already created, guidelines, information on those specific strategies, billing and coding guidance where applicable, workflow examples, dot phrase templates, and more things like that. And we will also share links to our diabetes resources and other resources here so that you can easily access it all in one place. And lastly, on my last slide, I'd love to, again, invite you to give us feedback as we develop these tools out. We'll be having a focus group looking at this particular platform and the tools we're developing for prediabetes on December 18th. And I believe, yep, that's a Thursday from 12 to 1. So you can scan this QR code. It will take you to our Calendly sign up. This does count for physician and practice level learning community VBR. And you can also access this on our learning community activities menu, which I'm going to turn it over to Jackie to talk about.
Thank you, Laria. Okay, I'm going to talk through our physician and practice level learning community options like Laria mentioned. So first, we're going to start with the physician level learning community options, but I wanted to take a few minutes to talk to you briefly about our learning community VBR activities menu. So all of you should have gotten an email earlier this afternoon that kind of walked through this option and how this is now available on the admin portal. So this is meant to really streamline the way that we give you this information and make it a little bit easier for you to access this and for you to share it with physicians in your practice. So you don't need to be logged into the portal to access this, but it's a one of the tabs on the left-hand side menu available on the portal now. So you can filter it by physician level VBR, practice level VBR, and there's another button on the live version now that says complete now that will show you any activity that, like, while you're signed in at that moment, you can kind of submit the information for and immediately get credit. We also have so that each of these expands and gives you additional details, including any links. So for example, the focus group that Laria just went over, if you were to expand this, it would give you like the sign up for that. And you're also able to download it as a PDF of your current view of the page as well. So if you have all of these expanded, it will expand all of them. If you only have a couple expanded, it will only expand those. So we hope that this makes this easier for you to share out this information and for you to find this all in one simple place right on the portal with all of the links and all the information that you need. Let us know if you have questions about using this, but we think this will be really helpful for you moving forward. So one of the things that's come up in meetings in the past is just interest in us spending more time on like some of these value-based reimbursement requirements and making it really clear to you how to meet these and what you need to do for them. So we're going to briefly go through these. I'll go through the ones that have been available multiple times more quickly. So our learning community events, we've had this as an option for physician level attendance for the last couple of years. For the live versions, we also offer continuing education at those. And then if a physician's unable to attend it live, you can earn credit by viewing a recording of the learning community event and submitting a brief quiz. Though this doesn't provide CE, and also it must be the physician that's in attendance. So if someone else from the practice attends, it doesn't meet that requirement for the physician. And the way that we've come up with these learning community event topics is at these meetings each year. So at the fall regional meetings, we've been asking you each year what kind of topics you're interested in seeing and learning about at these. We're actually going to do that right now. So this is our last poll of the evening, and I'm going to go ahead and launch this. And we'll give you a few minutes to just type in a single topic that you're interested in hearing about for next year. And then what we do is we take these different responses at the learning community events, and we go ahead and make our schedule so that we know the topics that you want to have covered and are able to address them for you. So I know this one may take a minute or two more for you to fill out than some of the others. So we'll give you a second there to do that. All right, we'll give people about 30 more seconds to submit this before we move on. We won't be able to review the options after this one since they're all text entry ones, but when we after we have the second regional meeting in November, we'll report out to you on the different topics that we're going to be having for next year's events and the schedule for them. Okay, I'm gonna leave the poll open, but we'll move on. So another continuing opportunity that we have is the CGM User Experience Program. So the idea behind this program is to give physicians firsthand experience of wearing a CGM themselves so that you have a better understanding of what that patient experience of wearing a CGM is. We now have this available for both Libre and Dexcom. We were able to add Dexcom this past spring as an option. Each physician is eligible to try each of these CGMs once. So if you've already done the Libre User Experience Program, you can still do the Dexcom one and get credit for that. And just as a note, the testimonial is what's required in order for credit to be given for this opportunity. So this is one that you want to leave yourself some time on, since we have to get your attestation, ship the CGM, give you time to wear it, and then do the testimonial. So this isn't one that can be done right at the end of the VBR year. So if you want to do this, would suggest planning ahead and doing it a little bit earlier on. A newer option that counts for both physician level and practice level learning community credit is our low carbohydrate diet workshop. So this workshop is 1 hour per day over 5 days with additional time spent outside of class working on some asynchronous tasks related to the course that are meant to enhance learning. We did this for the first time in the spring, and we've gotten really good feedback on it. 92% of participants agreed that the training helped them to better understand the concepts of low carbohydrate diets, and 85% of attendees agreed that the training helped them to identify ways to tailor dietary recommendations to patients and understand best practices for implementing low carbohydrate counseling. We're going to be offering this workshop again in the spring, and we'll plan to open applications in March or April next year. Attending the low carb diet workshop will also provide practice level credit and physician level credit if the attendee is a physician. So as you'll see, as we go through these, many of our options for practice level credit will also provide physician level credit. We'll note these throughout, so you'll know which ones will account for both. And if the attendee is not a physician, practice level credit will still be granted for participation in this. So really encourage you to take advantage of this workshop. This was in response to requests from the collaborative saying that you were interested in getting more intensive training on low carbohydrate diet. This is an option tool feedback that we previously had in VBR years, but we're revamping our approach to it. So we've narrowed the number of tools that are available for feedback to the ones that we're actively in the process of making revisions on. So right now we have one tool available for review. It's the physician-focused UACR tool. So if you have taken a look at that from earlier in the presentation, feel free to fill out this survey. It's an easy way to get physician level credit and also give us helpful feedback on a tool so that we can make sure that it's meeting your needs. Another option that meets both physician and practice level learning community requirements is participating in a site visit. We offer one site visit per region per year. So in the fall, we do them at our 3 regions that are more local to us in Southeast Michigan. And in the spring, we're offering them in the regions that we travel to. So Grand Rapids, Kalamazoo, Traverse City, and Saginaw regions. We'll notify eligible practices when these applications are open. And then in order to receive physician level credit, in addition to the practice level credit, a physician must attend a portion of the site visit. So we'll notify you what those requirements are. And these are another thing that have been really helpful for practices and that we've gotten great feedback on. We've been able to go in and give one-on-one support on whatever you need within the practices. So around implementing CGMs, around understanding the performance measure, on getting access to the dashboard, we're able to work with you in a more one-on-one setting, which has been really helpful. We also, finally, our last physician level option is to participate in an MCT2D feedback session on the admin portal or the website. We have 3 sessions that are open per month, and you could go on and sign up for one now for in the future. These will take about 20 minutes per session, and you can choose which you give feedback on, the portal or the website, based on what you use. And on that learning community event options page that we covered earlier is where you'll be able to access that. Okay, we're going to now switch to reviewing the practice level learning community options. So some that remain unchanged from previous years, and we've already reviewed these in the physician level session because they're ones that provide that dual credit. So I'm not going to spend time going through them again, but these are included in the slides that were sent out so that you can reference them. One of our new opportunities that we're really excited to offer you is our motivational interviewing practice sessions. So Amy Schneider is a RD and a diabetes educator who presented at one of our learning community events earlier this year on patient behavior change and motivational interviewing. And Amy's offering coaching sessions now with a simulated patient interaction where Amy will play the role of a patient with a type 2 diabetes. You'll go through just like you're talking to a real patient. And then right after that, Amy will give you feedback on the session to help you hone your motivational interviewing skills. And for anyone who's uncomfortable with the patient simulation portion, Amy's also willing to do coaching sessions without that component, though I would encourage you to try it. I think it's a nice opportunity to get feedback on someone who has experience in this and is acting as a patient. Many of you have asked for support with motivational interviewing and support with patient behavior change over the course of the collaborative. So we think that this will be a really great resource and will be really helpful to you all. Another way to meet the practice level requirement is to participate in an MCT2D focus group. So we'll be hosting one of these on prediabetes in December, like Laria mentioned in her slides. Not only is this a way to meet the practice level requirement and the physician level if you're a physician, but you're able to give direction on important initiatives within the collaborative to make sure that the things that we're developing work for you and meet your practice's needs. We're also planning on offering MCT2D surveys throughout the year on various topics related to the focus of the collaborative at the time. We've been doing these in May prior to the end of each VBR year, and now plan to offer another one in winter as well, giving you a couple opportunities throughout the year to meet this requirement via a survey. Please do note that this is separate from the census survey that was distributed in September, and also let this serve as a reminder for the census survey as well. If your practice hasn't already completed this, please make sure to do so by December 1st. Logging into the patient data dashboard twice during the performance year to review practice level data will also meet the practice level learning community requirement. This is especially relevant as we have increased performance measures with the UACR one now added this year, as well as the A1C measure. If you don't have access to the dashboards but are interested in getting access, please reach out to your physician organization and they can help you get set up there. We're working on launching a new practice level option to integrate an MCT2D tool into your practice workflow and then share with us like how you've done that and what you've done. We'll be providing information soon on the details of how to meet this requirement if this is something that your practice has already done with one of our tools or is interested in trying. Another new opportunity that we're adding for this performance year is to share your process on implementing CGM data into your practice's workflow for those of you that do have a successful established process. As we identified at the spring regional meetings this year, many practices don't have a standard process in place for receiving patient CGM data. So we've created a forum for those practices who do have a strong process to be able to share that information. We'll then be using that to develop and share best practices with the collaborative so that we can learn from who is doing this well and provide guidance to those of you who want to get a process set up. Then referring a patient to our MCT2D patient advisory board is another way to earn practice level credit. Just speaking to the patient about the opportunity and providing MCT2D with their contact information will serve to meet the requirement, whether or not the patient ultimately ends up joining and being a part of this. And then we also wanted to let you know that we did remove a couple options that were previously available from the practice level. We removed our dot phrase submission option as we revamp how we share this information in a more user-friendly way. We currently have it on Airtable and we find that a little bit hard to search and get the information that you want. We've also removed participation in the advocacy work group because we wanted to align how participation credit was given across our different work groups within MCT2D. And then lastly, we removed the option to provide patient level feedback on a tool because this wasn't being used in the way that we intended, where you're actively partnering with the patient to get answers and responses on that. So we decided to move forward without that one. And then one change to the scorecard that we wanted to make you aware of. So if all of your physician and practice level learning community VBR options are completed by January 1st, 2026, your practice will earn an additional 5 extra credit points on the VBR scorecard. So these points can be used to increase like your score up to 100 points. So if you lost points via one of the performance measures or meeting attendance or another thing, or not completing the practice census survey, if you missed it, these can be used to increase your score back up. If you go over 100 points, you won't receive additional value-based reimbursement on top of like the 5%, but this is a good way to give yourself kind of some padding and extra space to miss something else on this by getting those done early on. And with that, that is all that we had for you today. Thank you all so much for attending our regional meeting tonight. It was so great to hear from the practices on how they're working with UACR screening and how they've been able to be successful. We really appreciate you all being here and being so actively engaged. The last reminder, just please make sure when you exit the meeting, there should be a survey evaluation that opens up in a different browser. And you'll need to complete that in order to receive credit for tonight's attendance. Our team will remain on the call in case you have any questions that we can answer. Other than that, we will adjourn for tonight. Thank you to everybody.
Thank you so much. Oh, I love all of the hearts and the things in my screen. Anyone who has any questions wants to unmute. Oh, so many hearts. And thanks to all of the presenters.
Quick question. I had put it in the chat. This is Dr. Sarvapalli from Edmore, Michigan. If the patient does not get lab drawn on the same day and we obtain a urine albumin creatinine ratio, how does that work? What can we do about it?
Does anyone from the team want to take that?
Can you repeat the question? I'm sorry, I couldn't quite hear you.
So I know some of the practices are obtaining the urine albumin creatinine urine in the office. And what if the patient does not get the EGFR blood draw on the same day, what's going to happen?
So for the purpose of the performance measure, eGFR is not required for the MCT2D performance measure. It is only urine albumin creatinine ratio. So the two required tests are urine albumin and urine creatinine. So that's for the purposes of the the MCT2D performance measure. So for your participation in MCT2D, you don't need to worry about eGFR. Obviously, eGFR is a very, very important component of kidney care. And for the HEDIS measure, that is a component. And so what we're doing right now is we're trying to verify whether or not eGFR is required to be collected within a certain duration from a UACR, or if it can be just collected during any time during the measurement period. There's a little bit of ambiguity of that right now. So we're trying to find that out. But that is, again, only related to the KED HEDIS measure, not MCT2D's performance measure.
Hi, this
Thank
is
you.
Rodrigo Tobar. I'm a family physician. We get these forms from Honest for the patients. Honest is Blue Cross Blue Shield is part owner of Honest Health, which is there's various POs that participate with this. And we get forms that measures have to be met. And it just started appearing probably within the last 6 months that says in order to count, you have to have the eGFR on the same day you get the urine albumin to creatinine ratio. Otherwise, it doesn't count. And that's absurd, because again, a lot of times patients can't urinate the day they come and they get their blood drawn. They can't give you urine. So then you got to do the whole thing over again. You have to do another visit. So I don't know. I guess that's my
Or we are
confusion.
already dealing with a patient who doesn't care, and we, kind of forcibly got a urine specimen on him. He's never going to go and get a blood draw. One of the patients told me that today, that he's just not going to do it. Yeah.
These are really helpful feedbacks. I don't think I was aware that there was a same day or with a contiguous limit. It sounds like a really important opportunity for advocacy for us. And so we'll start with Blue Cross Blue Shield and connecting with some of the NCQA folks and get back to you. I think part of the reason that MCT2D is just focusing on urine albumin creatinine ratio is that is under our locus of control to perform that test.
Thank you.
Can,
Appreciate
can
that.
you can you hear me?
Yeah.
Yeah, this is Dr. Grimshaw. So I have never heard from any of the insurance plans, from any of the HEDIS measures, that it has to be done on the same day. It's once the blood draw is anytime during the year.
That was
That is
my impression
That's
until
our
today.
understanding of it as well.
Yeah,
Mhm.
yeah. So there seems to be some disagreement there. So we're trying to figure out for sure. I think it's worth us reaching out to the collaborative after we get final word, but
Okay.
we'll follow up on that. The way that the measure is written, we agree that it says during the measurement year. So our fingers are crossed that that is the case.
Okay.
So I
because-
do have a question that I put in the chat earlier. How do we leverage MCT2D to try to put pressure on the insurance companies to pay for the CGMs? Because that literally has been the biggest thing that has been get patients to change their lifestyle. In 20 years, nothing has worked as good as getting a CGM on a person. So how do we keep the pressure on them to try to get them to make it so that all patients could get this?
I will answer that while it is not a conflict of interest that Blue Cross Blue Shield funds MCT2D, I think of advocacy as inside and outside. There are things that we can do inside as a great partner by continuing to present data and information. And the person who suggested identifying worsening care with elimination of CGMs for the collaborative members, that's a data analysis study that we can do. Outside, I think we need to figure out how we can support people sending independent letters, and that can come from patients and physicians. Maybe that comes from someone talking to their newspaper or their legislator, and kind of keeping that fine line between MCT2D not being an advocacy organization, but advocating for our patients.
So
Heidi can
is
chime in.
anybody mining the data currently to actually look at the changes in A1Cs from before CGM to after?
We
So
haven't, go ahead, Heidi.
I I have a quarterly PharmD meeting of the PharmDs in MCT2D. So when I met with them a week ago and shared this news, I said that's what I want to do it retrospectively and then start monitoring forward for the next 6 to 9 months and then present it to Blue Cross as my plan. There were people that were privately messaging me during the meeting saying, what can we do? And I said exactly that to them. So that's all I have at this moment. But that's my plan.
Okay.
And I
Of
think,
what
Heidi,
I'll
the
be
other
doing.
piece of, cost effectiveness and, providing, even if it's just a one pager and not a research study of, what the impact will be when people's A1C goes up by the 0.5% that we know it will, because there are, very, very clear meta-analyses of clinical studies on CGM for non-insulin dependent type 2 diabetes, demonstrating that's the benefit. You take it away, this is the implication. So those are things that we can put some time in as a collaborative. I think separately, there may be some opportunities for us to engage in clinical studies where we can start to produce this more robust information. What is the ideal amount of time and way to use CGMs in order to get good outcomes? And I think my impression is that we can provide ideas to Blue Cross. And if that best idea is, wow, 6 CGMs a year with different educational interventions improves care, that may be something that changes in the future.
I think the
Okay.
other piece of education that's come up just in the last few weeks that we've learned of this news and I've dove into the data is DMEs charge to a payer 3 times the cost that a pharmacy does. And so if you're a payer, it behooves you to send it to a pharmacy because then there's rebates that payer can receive. And so part of my idea in gathering data is then to also go back to Blue Cross and say, hey, it's a lot cheaper if you put this on the pharmacy benefits, but I think a lot of payers are afraid to put anything on the pharmacy benefit side right now because of their pharmacy benefit cost. But
Right.
the piece of information that I've used already, within self-employed groups such as Michigan Medicine is in talking to our benefits office recently with this change is to find out this piece and if things should change, like, hey, what can we do for our employees? Like this is, and I gave to our benefits office case examples of employees that lives were changed and that mattered to them. So, Michigan Medicine Benefits Office is much smaller than Blue Cross Blue Shield, and they want their employees healthy. So I was also chatting in privately with people messaging me during the meeting is this is the small bit of grassroots movement that we can do is get to these carve out plans and say, hey, this matters. And so change this coverage and maybe it gets bigger. I don't know, but that's what I plan to do.
So Jackie,
Okay.
I don't know if we can mail people postcards to send in, but I know as we send out that FAQ about Blue Cross's responses about removing this coverage, let's go ahead and give some sort of email or person who's willing to take testimonials, information. I think we need to have Blue Cross serves its beneficiaries, which are our patients. Our patients need to be activated to complain. Maybe the state of
Yeah.
Michigan starts requiring all insurers to cover CGMs for diabetes. I don't know. Maybe we start thinking about an advocacy day.
I think that's a great idea. I think you almost need to go above the insurance companies, and the benefits are it's tremendous.
Yep.
Heidi and I have gone through the stages of grief. We're here to support everyone through them.
Oh, I know I'm going to have patients with meltdowns.
Yeah.
Any
Any other questions? Go
to
ahead.
this that agree completely.
Yeah. People who are still here are here because they care.
Exactly.
Well, thank you.
Thank you.
Thank you.